Good morning, everyone. Welcome to this session. Pulmonologists as the gatekeepers of precision medicine. How much is enough tissue? So my name is Momen Wahidi. I'm an interventional pulmonologist at Duke University Medical Center. I have the pleasure of having Dr. Dean Wallace here, pathologist with interest in lung pathology, who is the chief of pulmonary pathology at UCLA. And today's learning objective is really to talk about the current guidelines pertaining to adequate tissue acquisition and its implication in non-small cell lung cancer, and also recognize the importance of obtaining adequate tissue samples for the diagnosis of non-small cell lung cancer, including molecular analysis. And I'll turn it over to Dean.
Good morning. We'll talk about this next case. In this case, we're going to go into the hood a little bit in the pathology lab to have a better understanding or idea of how we handle the tissue. And while it's very important to have a good sort of team approach to assessing these patients. So this patient is Pete, a 67-year-old man with a history of smoking and a growing right upper lobe mass with apparent metastases. On clinical staging or imaging, we're seen to have a right upper lobe mass, a liver lesion, and a right adrenal lesion. On imaging study, you can see the spiculated mass in the right upper lobe is very large. You don't see lymph nodes, but on the spicular slice. He also has a liver mass and maybe an adrenal mass here. Interdisciplinary discussion is needed to decide which is the best site to obtain tissue from. That's both sufficient for diagnosis and molecular testing. Consideration is given to the invasiveness of the procedure and local resources and expertise of the proceduralist and the pathologist. Having rows is a great resource, but you need to have a clinical team or a pathology team that's set up and is able to provide those resources. Developing an algorithm based on the patient's apparent clinical stage is very useful and is also useful for handling the tissue in the laboratory. As Dr. Wahidi just said, acquire tissue from the highest stage locations and then order EGFR and EML4 ALK and all advanced adenocarcinomas. I'll hand this over to Dr. Wahidi in a second to talk about the Rose procedures. I don't do it as much as Dr. Wahidi does. Needle aspiration of the target. The aspirate is discharged onto a glass slide. You literally squirt it onto the slide, and then the tissue particles from the aspirate are selected and smeared on two slides. One slide is air dried and stained with Diff-Quick, and that's used for the Rose procedure. The other slide is placed in alcohol, and that's used for Papa-Nicolau staining. The purpose of doing those different stains is they have different properties, and it makes it easier sometimes for the pathologist to see one lesion versus the other. The remaining specimen is allowed to form a clot and put into formalin for for cell block preparation. This cell block functions as any other needle core biopsy, and all molecular testing can be done on that cell block, as can other special stains, H&E or IHC stains. The needle is washed with saline in the cytolite fixative, and then if more material is needed, if the Rose is non-diagnostic, then the procedure can be repeated.
I think I want you to see this because as a pulmonologist, obtaining the specimen, you actually have the needle, the source of the specimen. And it's important for you to know all the steps from a sort of pulmonary standpoint. So we're going to take that needle, express the tissue on a slide, smear it, and then some will go to air dry, and I'll show you in pictures, to be immediately stained and evaluated. Some will go to alcohol stain, and some will go to a cell block so the lab can do more testing. So we're going to look at this in actually pictures, which is much easier to understand. So I got my needle, whether you or you're the assistant. So they're taking the needle. You can see they're putting it on a glass slide there. You express a little, but you don't want to put everything there on the slide. You put a little dot there. The rest is going to go to cell block. And then the technician or your nurse can smear it and make these two smears. And then one is going to go to alcohol. One is going to be dried. Just wait for it to dry. And then you're going to go actually do a Diff-Quick stain right there. That's what the pathologist team brings with them. They bring these little containers, and they have 3 chambers, blue, red, and purple, and then they put the slide in each one of them about 10 seconds, 10 seconds of blue, 10 seconds of red, 10 seconds of purple. They bring it out, they wash it to get rid of extra stain, and now it's stained nice and purple, and that's what they're doing to look at the microscope right there outside your suite. But for you is remember, put a little bit on the slide. The rest has to go to cell block. That's the gold liquid that the radiologist is going to take and do some more testing, hopefully do the molecular markers. And this is just another illustration. So that's the diff-quick. That's the alcohol. You know, remember we made 2 slides. One went to diff-quick staining. One goes to 95% fixed alcohol for further testing in the lab. And then remember, I mean, we're talking about lung cancer here, but if you're suspecting maybe infection, you want to do culture, you can't put it in cell block. You have to put it in saline. Or if you're suspecting lymphoma and want to do flow cytometry, you cannot put it in cell block. You have to put it in saline or other media that your pathology folks will tell you. The others are more research. If you're doing some research on DNA, RNA, you have to freeze it. So I'll give it back to Dean.
All right, thank you. Yeah, that's always an important point with microbiology, especially in this part of the country where we get a lot of coccidiomycosis infections. That's not an uncommon scenario at all where we have a suspicious mass and it comes back as an infectious granuloma. So if the rose demonstrates that it's a clear malignancy, then the radiologist doesn't bother. But if it's equivocal, then they always submit some for microbiology. Okay. So each of the following markers, molecular markers, would be appropriate to order for our patient except EGFR, ALK, KRAS, or ROS1. Interesting. So EGFR and ALK, obviously, we mentioned it there. It's recommended to order EGFR and ALK on all advanced lung adenocarcinomas. KRAS is an older mutation. We used a molecular test that we used to test much more for years ago. But there's no therapy for KRAS. And there are actually relatively few clinical trials that target KRAS. ROS1 is newer. It's quite rare. We see it, they say 2% of the time. It seems like it's more like 1% of the time in my practice. But we do have targeted therapy that's actually very effective for ROS1. So even though it's rare, it is recommended by the NCCN, for example, to do ROS1 testing as well. So the answer is 3, KRAS. Okay, now again, talking about getting under the hood of pathology. Within pathology, there are various labs, and the labs have to communicate to each other to maximize both the utilization of the tissue and shorten the turnaround time for the different tests. So histology works with cytogenetics, cytology, and molecular markers, and the tissue has to be shared. So, and many labs don't do testing for every single molecular marker, so they have to send stuff out. And how long do the tests take? I very often get called, not as much as I used to, but I used to get called 2 or 3 times a week looking for molecular studies. And then after a couple of years of me saying, I don't do the test that goes to molecular lab, maybe either they've found the molecular lab's number and they call them, or they realize it takes a couple of weeks to get the results back. But what I do in histology and with IHC can impact how much tissue I have left over that can be used for cytogenetics and molecular studies. And importantly, cytology specimens can also be used for cytogenetics and molecular. Cytology often has less tissue than like a larger needle biopsy or a surgical specimen, obviously. But if it's properly handled, that can produce enough material to do all the additional testing you need. FISH tests are relatively fast. If you have a good laboratory and a good workflow, you can get FISH tests, meaning the ALK and the and ROS1, you can get back in 2 or 3 days if you have a good workflow. Molecular testing, depending on your lab and what modalities you use, can take anywhere from 5 days to 2 weeks, 5 working days to 2 weeks. When we receive tissue or the cell block, it gets embedded into paraffin. And then to utilize that tissue, we have to cut sections from that paraffin tissue. Okay? Here are examples of where we cut the sections. So the first level that we cut is stained with H&E, and the pathologist uses that. The next 4 levels are all unstained slides. Okay? And they're set aside for immunohistochemistry. So if we need to do any special testing, we can do it with those 4 slides. The next slide, again, is H&E, because sometimes the tumor is not on the first level, it will be on the next level, a little bit further down. And then we cut all these slides, 7 through 25, which are a lot of glass slides, that are set aside for molecular testing and FISH testing. Then 1 more H&E, level 21, for a pathologist again, and then some negative controls for immunohistochemistry. Okay? That's a lot of slides that we cut through. That's a lot of glass. Our histology manager, she doesn't like it, but it has actually increased our yield for molecular testing and FISH testing from 75% to 95%. So before we implemented this, we haven't published this data, but anecdotally in our practice, Before we implemented this particular method, we would have, as I said, about 30% of our cases or 25% of our cases, we wouldn't have sufficient tissue to do all the testing. Now, that's about 5% of the time. It involves more work from the histology lab, but it does make that tissue that you receive go much, much further. The reality is if you don't cut all the glass up front and you have to go back to the block, you lose tissue. So every time you go back to the block to do more testing, you lose tissue because the tissue has to be effaced, and so you lose tissue. So if you do IHC, and then you go back and you do molecular testing, then you go back and you do cytogenetics testing, a lot of the time you don't have sufficient material to do everything. All right, so this is, we did a needle biopsy on this patient with an aspirate. And here you can see it's a cellular aspirate, and here you can see the lesion itself, a lot of ugly looking cells. And here's a cell block. Often the cell block, you don't get a lot of material. But here we can see at high power, it's composed of these glandular looking structures. So what are the findings? Is it a squamous cell carcinoma? Is it a carcinoid tumor? Small cell, this patient who smoked? Or is it an adenocarcinoma? Adenocarcinoma. That is correct. So it's composed of glandular components. So it's a very straightforward adenocarcinoma. So would you do IHC at this point, immunohistochemistry? And if so, what would you do? TTF1, P40, both, or neither? So the IHC is a label to help indicate what type of tumor it is and where it's from. Okay, that's interesting, both A and B. And that's a recommendation for any poorly formed malignancies if you want to distinguish adenocarcinoma from squamous cell carcinoma. In this case, we know it's adenocarcinoma. So if it was P40 positive, it would be a P40 positive adenocarcinoma. So we would never turn this into a squamous cell based on the IHC. So in this case, the answer would be TTF1. Okay? Again, we want to save as much tissue as possible, much material as possible. Some people might not even do the TTF1 and just say, this is adenocarcinoma. What is TTF1 going to do? But I would always get the TTF1 just to make you feel good as a pathologist that it's from the lungs. And here's that slide. The brown staining is the positive staining, and you can see this is strongly positive. Okay, so what ancillary tests are needed at this point? Molecular studies. EGFR, that is the one recommended molecular study. Do we need any special tissue handling? Do we need to do anything special or upfront? No. All the testing can be performed on these paraffin-embedded or formalin-fixed paraffin-embedded tissue blocks, which makes it easy for everybody. FISH studies? Yeah, ALK and ROS1. I should clarify, ALK is absolutely recommended on all advanced adenocarcinoma cases, and ROS1 is recommended by the NCCN, okay? It's rare. As I said, even in our practice, we get maybe one a year, but our oncologists are so enthusiastic about treating patients with ROS1 because there is a target, crizotinib is one of the drugs, that we always get ROS1. And then PD-L1 staining. It's kind of all the excitement, all the rage nowadays. Yes, we do get PD-L1 staining. And then the question with PD-L1 staining is what PD-L1 antibody do you use? So there are different antibodies that correspond to different therapeutic treatments. And so the pathologist and the oncologist have to compare notes and match up, make sure they get the appropriate antibody for the drug that they use. PD-L1 expression is lower in adenocarcinoma than squamous cell. In squamous cells, the expression is 35%. In adenocarcinoma, it's about 25%. Now, if it was a squamous cell carcinoma, what testing do we do for squamous cell carcinoma? The only testing we do for squamous cell actually is PD-L1. As I mentioned, there is higher expression. So if it's a squamous cell carcinoma, we wouldn't order EGFR, we wouldn't do ALK, we wouldn't do ROS1. If the clinicians ever ask, and we always do it, we don't fight them. Every now and then we'll actually find a positive EGFR mutated case in squamous cell carcinoma. Often in patients who have if they are Asian or they have a very short smoking history or a very minor smoking history. It's rare, but we have found EGFR mutated squamous cells. And as I mentioned, just to reiterate, all the above testing can be performed on just regular pathology specimens, the formalin-fixed paraffin-embedded tissue. Again, making it much easier for all of us. So in this particular patient, he had an L858R mutation, that's an EGFR mutation, that corresponds with sensitivity to the tyrosine kinase inhibitors, like erlotinib. The ALK result was negative. There was no evidence of translocation. ALK is positive in 3% of adenocarcinomas, a little higher in Asian patients. And the PD-L1 staining in this case was 0%, which is negative. Okay, so molecular testing guidelines, as I mentioned. The guidelines from the CAP, the IA, SLC, and the AMP, which is Association of Molecular Pathology is that advanced stage adenocarcinoma prioritize EGFR and ALK testing. They encourage testing, encourage is exactly how they say it, on any stage of lung adenocarcinoma. But it's only strongly recommended in advanced stage. As I mentioned, the NCCN guidelines also recommend ROS1 as an additional consideration. PD-L1 staining. As I mentioned, you have to match up the stain with the particular targeted therapy. So the 22C3 antibody goes with pembrolizumab, 28A antibody goes with nivolumab, and the SP142 goes with atezolizumab. So it's a big deal for any lab to implement the antibody and the staining platform, because they're different platforms. So the labs have to make a strategic decision as to what antibody they'll go with. You can also send out, if the lab doesn't have staining in-house, you can also send out to a reference lab to do the staining. Importantly, the pathologist must remember only to count the membrane staining and provide percentage of positive cells. So to summarize, ROSE recommended to ensure adequate tissue, provide molecular markers, and to confirm the diagnosis. Optimized handling of the specimen by the pathologist and the pulmonologist can increase the diagnostic yield. A minimal IHC panel is recommended. If it's an obvious squamous cell carcinoma, I don't get any IHC. If it's an obvious adenocarcinoma, you may just get TTF1. Or no IHC at all if the clinical picture is a very obvious lung primary. The recommended molecular panel, as I mentioned, EGFR, ALK, and ROS1. The extended panel that Dr. Wahidi showed in the last slide of his presentation can be performed, but most of those other mutations are only associated with clinical trial drugs. And then PD-L1 staining is increasingly demanded, but as I said, you must match the stain with the specific targeted therapy. So this 54-year-old male smoker had the following CT scan, a PET scan showed FTG uptake in the nodule and a 4R lymph node. Which of the following should be performed next? Transthoracic needle aspiration, EBUS of the 4R lymph node, VATS, or repeat PET scan in 3 months? And the answer is EBUS. The following biomarkers are recommended for ancillary testing for advanced non-small cell except EGFR, ALK, KRAS, or ROS1. KRAS, yeah. So KRAS, we don't have any specific therapies for KRAS, so it's not recommended to do the testing.